Hello and welcome to Lifestyle Dentist Podcast. I'm your host, Garth Hatch, and super excited for our guest today. We're going to be talking with Dr. Bruno Acevedo. Dr. Acevedo is an oral and maxillofacial radiologist. He's basically an endodontist. He's got like a few weeks left of his endo residency, which that's another fun part of his journey that we'll get into in the podcast. But he's been practicing as an oral radiologist for decades. Basically, it runs in his blood, and we'll be able to cover that. He's also a Brazilian Jiu-Jitsu black belt, which if anybody knows anything about BJJ, that's like legit. That's like a legit killer. It is like the 1% of 1% in the martial arts world. So yeah, you don't become a black belt just by signing up for a couple classes. He's the kind of guy you'd want to have around if things hit the fan.
Yeah, I can run faster than most.
So glad to.
It's all good.
Yeah. Yeah, you want to be on his good side, not his bad side.
Run away.
So glad to have you, Bruno. And just on a personal note, I've known and followed Bruno for years. I've taken classes with him in cone beam. He's also known as the cone beam guy. He has training programs with that. And just you're an amazing educator. You can explain complex things simply, which I think that's the sign of a teacher, instructor, somebody who can break down something difficult and make it easy to understand. Anybody can take something complicated and make it more complicated. That's not a good instructor, but somebody who can take something complicated and make it simple. And so, yeah. So glad to have you on the podcast, Bruno.
Garth, thank you so much for the invitation. I'm pumped to be here. I think it's going to be a great podcast. And I'm looking forward to this conversation. I think it'll be fun.
It's going to be fun, and depending when this episode comes out, I mean we're here on Memorial Day. You had we're hanging out with a good friend of mine, Mike Thompson. But both of we both know Mike, and just by chance both got a message from him and you that you guys were hanging out. So yeah. How was the weekend hanging out with Mike?
Fun, right? Lots of really good food, good conversations. Awesome. Anywhere from music to endodontics. I mean, he's a great guy. Working hard guy, just like yourself. So you guys went to the program together.
That's definitely.
And it just shows you that the world is so small.
It's so true, especially in the dental field. So yeah,
it's so
yeah, good conversation. Probably some great sushi or some other good food.
Yeah, you know him. Yeah, so definitely we went to Morimoto here in Philadelphia. Steak 48 on Friday. It was just great.
Ooh, that sounds good. Yeah, that sounds awesome. Good. Well, I'm sure many people do know you, Bruno, but for those that don't, who is Bruno Acevedo? Maybe a little background about you. Where'd you grow up? How'd you get into oral radiology? For the guest to get to know you a little better.
The first thing you're going to notice about me is that I have a very heavy Southern accent. Okay, but it's the true Southern accent. It's actually from the south of the equator. I was born in Brazil, and I came from a family of radiologists. My dad is a radiologist for maxillofacial radiology, has always been in the business of radiology. I grew up in an imaging center in Brazil. Cool. My passion from martial arts and jiu-jitsu, that kind of stuff, comes because I grew up with that culture. In Brazil, you had two options: you can play soccer or you can go fight. So they're the only two things that were available to boys when I was growing up. And it just so happened that I wanted to learn how to defend myself. Jiu-jitsu had this mysticism back in the day. There was no UFC or anything like that. We heard about all the Vale Tudo fights, and we knew that what Jiu-Jitsu was. Interesting enough, we don't call this Brazilian Jiu-Jitsu in Brazil. It's just called Jiu-Jitsu.
Jiu-Jitsu, right. Yeah, you're in Brazil.
so I wanted to do that. So anyways, that started my career. I went to dental school knowing that I wanted to become a radiologist. So, which is kind of unusual for most people. Like I heard your podcast, so like you went to dental school, you know nothing about dentistry, or you just knew that you had the lifestyle that you kind of wanted. In my case, was a little bit different. I already knew all the other specialties. My dad was in radiology business, so all his friends were oral surgeons, endodontists, periodontists, prosthodontists, that kind of stuff. So, and I knew that I was like, I don't want nothing to do with this. I want to do what my dad does. I want to go, get myself into a dark room and look at grayscales all day. Went to dental school, and started a radiology program. Did my radiology program in Brazil, but what ended up happening was uh, that in between. We went to this space in radiology that we were starting to go in between technologies. So back in the day, back in the late 1990s, early 2000s, everything was still film based. There was not a lot of 3D imaging going on in dentistry. Then we started with linear tomography that was driven by necessity of cross-sectional imaging because of dental implants. And um, we started to get interested in now in medical CT scanners. They became affordable enough that an imaging center could purchase one for an insane amount of money. Don't get me wrong, but the
Well,
whole
because yeah, you started in like 2003, right? I mean, that was
yeah.
like
So
early days of
we
where the
bought
imaging
our
being.
first Combin CT scanner in 2003,
Yeah,
and
yeah,
and
that's
what
like
ended
the
up
early
happening
pioneer
was
days.
that we bought the first small field of view high resolution CBCT scanner in Latin America. At that time, I think there were like
Wow.
16 in the world, something like this. We got one of the first 20 units in the world. We got it,
Hmm.
and the whole idea was that we were now working with small volume, high resolution, three-dimensional imaging in dentistry, and the field of view was a 3 by 4, the size of a periapial radiograph. All right, so uh, we started work with this machine, and interesting enough, we were in the imaging center business. When we installed the machine in 2003, I asked the Japanese engineer at the time, say, hey, how do I put together a report? If you remember, old school medical CT, they have those big films with all the cross sectional images there, the
Hmm.
parasagittal cuts. So I wanted to
Yeah.
do that because that's what my vision back in 2003 on how to send somebody information. And the Japanese engineer goes, oh, there's no way to do that. You have to kind of look on the computer. And I was crying because we invested every single penny we had in buying this unit,
Yeah.
and suddenly we couldn't sell it to anybody. So
Hmm.
for the
Hmm.
longest time, I had to I had to stay all working nights in the imaging lab, and my job was to create reports on Photoshop,
Hmm.
where I was put everything in a sequence and draw
Yeah.
lines and stuff
Wow.
like that,
What a
to
pain,
and,
huh?
and, and
Jeez.
print those pages the next day to send it to my referrals. Um,
Hmm.
Meanwhile, I have a really good friend of mine who owns a software company that stayed behind with me for about 6 months, and we were programming software that would do some sort of automation of this process. So um, we started by designing something that would allow us to create the reports much faster, and then out of the blue, we started to play with some ideas, and we developed the first freeware home CT viewer in the world. So it was free.
Hmm.
And in 2004, if you were to send me a patient to my practice, imagine I could send you back a CD, kind of like what we do now, and you could navigate the volume. Very
Hmm.
rudimentary, but you could navigate and make measurements on your volume on your computer, right? So
Hmm.
that was fascinating. And in '04, I gave a lecture to the Brazilian Association of Radiology, and the keynote speaker was an American uh, um, radiologist, Dr. Robert Langley, who was the program director in
Hmm.
San Antonio, and
Yeah. Yeah.
he he's lecturing about this new technology, Combin. He has done like 300 plus cases, but he has no way to print the images or do some other things. And right after his
Hmm.
lecture is my lecture. I'm going, well, we've done 10,000 patients, and I'm going to navigate the volume in front of everybody here live. And
Yeah.
that led to an invitation to come to the US in '05, where I
Hmm.
stayed in San Antonio as a preceptor for a year. Then Langley
That's
looked at
cool.
me and said, "No, I don't want you to go back to Brazil. I need you to stay and do another 3 years for your master's." So I got in to the program in San Antonio, finished in 2009, and from there, I was hired to be a founding faculty of a brand new dental school in California, which was Western University.
Yeah.
And
That's awesome.
that was one of the defining moments in my academic career because I had a very unique opportunity to start a brand new dental school and
Hmm.
have a better understanding of how to integrate curriculum. So one of the
Hmm.
things that you were talking about me, that's, oh, I can break down knowledge, that
Hmm.
came from actually very specific training. So
Hmm.
when we started to put together this new dental school, I was the fifth faculty member to be hired. for this
Wow. Wow.
from this brand new dental school.
Just curious on that. How did that come to? Was that another meeting like Dr. Langley? Like just you met somebody at a
Yeah,
conference, or how did
so
that?
interesting enough, I was a consultant for Jay Morita
Hmm.
at the end of my residency. I was doing a lot of consulting stuff with them, helping them develop their 3D business in the United States, just because I've been using their equipment for forever.
Hmm.
And um, this dental school was developed by a doctor named James Coble. Okay, and James Coble had a friend in California who was also a dentist. Alone, and every time they were in the same city together, they always went out to go to dinner. Kind of like Thompson and I, like this week.
Yeah.
We're
Right. Right.
definitely going to meet up and go to dinner, right?
Yes.
Um, so
That's where the real magic
yeah,
happens, right?
absolutely. So
It's not in the lecture hall. It's in the dinner.
when Dr. Coble was in California, had just moved to California, he went to dinner with his friend, and his friend was like, "Well, my son, um, it's working for this company that sells 3D imaging, and you're putting this dental school together. You probably should talk to them. They have lots of dental equipment and stuff like this." And Coble said, "Set up a meeting." So I got a phone call from Rita and says, "Hey, we have to meet with this dental school. They're developing their plans. They don't really know what they're going to go and what direction they want to go. We want you to go there, just talk to them and show, what is the best way to design an imaging for a dental clinic." So
Right.
that's how I went. I went in as like just somebody that could kind of like, "Hey, I'm here on behalf of this company, but I'm here to kind of help you talk about imaging." And as I'm doing my thing and explaining, what the workflow should be, and what are the different types of hardware that they should be looking for, what the future is going to go, how could you integrate this in different types of software and scenarios. Um, Dr. Coble just looks at me and says, "Son, when are you graduating?" And I go, "Like in 2 months." And he goes, "Do you want a job?" Literally just like that. I was like, "What?" He goes, like, "You want to come to California?
That's
I
awesome.
want to hire you right now." So that was on the spot, and within 1 week, I had a contract signed, and within a month, I was actually in California, already
That's
working with them.
awesome.
So that's how it started. It was really one of those
Well,
things
props for
that,
him to spot talent.
yeah, he literally he had an eye for finding people that had special little things and that
Hmm.
could help develop the school.
Hmm.
So what was interesting about that particular time is that the whole idea was to create a curriculum that was fundamentally different than any other dental school in North America at that time. We were the first dental school to create a curriculum solely based on on what's called a block schedule. I don't know if you know what a
Hmm.
block schedule is. So
No, no,
typically, when
no.
you go
Yeah.
to dental school, right? What do? You have your first semester, and you have like all those disciplines that you're taking. You're taking anatomy, biochemistry, you know, whatever it is that they teach in
Hmm.
dental school, and you have
Yeah.
all those subjects being taught separately,
Hmm.
and you are the ones that have to connect the dots. They're not taught
Right.
in a sometimes in a precise sequence, and sometimes they are
Hmm.
taught in ways that you cannot connect dots. You don't know why you're learning this now because you're only going to learn
Hmm.
the importance of this later. And then sometimes you'll have to go back and everybody that went to dental school understands what I'm talking about here. Um,
Hmm.
our curriculum was proposed to be taught in a block schedule, meaning that you're only going to focus on one subject at a time. So you
Hmm.
don't have 8, 9 disciplines as you go along. You have one. So
Hmm.
you can dedicate yourself for 3 weeks to learn the biochemistry. Boom. And then what comes
Yeah.
next that ties to this? Oh, maybe this is going to be now anatomy. And then you, boom. And then,
Hmm.
oh, you learn anatomy now. We can put you now in radiology. So, there are different things that you can learn in a different sequence. It's the same concept, but you just focus yourself for 3 to 4 weeks in one particular subject.
Hmm.
And
I could see the benefit of that. I just offhand, I went to dental school in
yeah,
Indiana, and they were just starting it called problem-based learning,
yeah, PBL.
which
Yeah, absolutely.
yeah, PBL, which was almost opposite. It
We also
was
had a lot of PBL. PBL is important. So PBL is just a component of that because then you introduce a
mm,
problem and everybody has to figure it out how to fix it. Our
mhm,
school pioneered something a little bit different with PBL. So our
okay.
PBL was it was based on different colleges. So they would give us a clinical case, and in a room you would have a dental student, a pharmacy student, a medical student, a podiatry student, you know, a veterinary student, all the disciplines in there, and all those cases had some component to it, and we had to solve the case as a group. So once every 2 weeks, we had a whole afternoon of PBL cases, but it was never designed just for dentistry. It was designed for you to learn how to talk to your pharmacist, how to talk to, your podiatrist or your physical therapist, and so on and so on and so on. It was really interesting to do that. And I was one of the, you have the facilitators, and the facilitators were somebody that would just walk in a room, and although technically speaking, I'm a subject expert in dentistry, I couldn't say anything. I would just let the students talk. And it was fascinating to see some of the things that would come out of those cases. One good example was there was this person, he was elderly, and he was walking the dog, and he fell. And as he fell, he broke both of his arms, and there was like this whole scenario thing. And the interesting thing is, now what do? You have an elderly person that has a support dog, needs the help of the dog, but can't walk the dog because both of their arms are broken. Or how do they feed themselves? How do they do their oral hygiene? And so you go through all those things of clinical scenarios that you have to be involved and have all those students talk about. It was pretty fascinating. So going back to the curriculum part, we are now breaking down knowledge in ways that you say, okay, what is it that a dentist needs to know about this particular subject? And you say, well, this is the bare minimum that they need to know, and this is the reason why they need to know this, and this is how they're going to apply this information in clinical dentistry. And by the way, with this information right here, I can connect this to the next block. So it almost becomes this Lego building kind of a mentality thing. And what was very interesting to me is that from the beginning, I was putting together my radiology curriculum, and it took me a full year. Imagine this, a full year as a board certified radiologist to write a simple sets of lectures for one semester. And the reason for that is I had to literally break down every single thing I was teaching. I was like, well, why do I want students to know the physics of KV and MA? And how I'm going to apply this, and what kind of the questions I'm going to ask. And then, Garth, just to give an example, I had plotted how many minutes per lecture I would talk about a certain subject and what I want the outcome to be. I would measure that outcome. And if it wasn't there, I knew, for example, I taught about something for 20 minutes and everybody got it right. So perfect. This is what I wanted. And then I taught something for 10 minutes and 80% of the class got it wrong. So what that tells me is that next time I teach this class, 10 minutes is not enough. I have to emphasize with more things. So you start to understand how people learn and how to break down knowledge into tiny little cubes of knowledge, as we call it, to make things flow in a sequence that makes sense. So you've seen me lecture before. You go for a 3-hour lecture with me on radiology, and you're on the edge of your seat from the beginning of the lecture to the last slide. And people are like, how do you do that? Everything is by design.
I don't think you could underestimate that, because really that explains a lot, in a lot of ways, because I think most lectures in dental school, most programs, it's a curriculum that was taught by another doctor, by another doctor, by another doctor, and you trace it back. It's, almost the same stuff they were teaching in the 60s and 70s.
Correct.
Obviously they continue to add to it, but a lot of the curriculum is the same stuff that for decades.
Correct.
And
so I'll give you an example. When I
good and bad, but you basically started from scratch. Basically started from scratch and said, let's get the real meat, and that explains a lot how you can explain things so much better.
Yeah, so just to give an example, I left California to Louisville in 2014. Louisville is the largest radiology department in the United States, in any dental school. That's the one that has the more toys, the more developed radiology program. So I walked in now as a director of radiology. I was filling the shoes of probably one of the greatest writers and researchers of radiology. I always had a guy named Alan Farman, and the first thing I did when I sat down with my chair, Dr. Scott, who's also a radiologist, I looked at the curriculum and goes, everything is wrong. And he just looked at me and was like, well, you've been teaching this for like you said, 25 years. I was like, everything here is wrong. So let me give you an example. The students, when I walked in, they were having a lecture on panoramic imaging, but they never had anatomy. So imagine have a lecture on panoramic imaging where you never had anatomy. You don't know what a mental foramen is, right? And you're now learning anatomy in 3D, which is extremely distorted. So in 2D, that's very distorted. So made no sense. And we were going through accreditation in 6 months. And I said, I don't care we're going through the accreditation. Give me 2 weeks. I'm going to redo the whole thing. And you're going to have to trust me on this. And he, with a blind eye, he just go like, dude, this is accreditation time. If you're telling me this is going to help, go. And guess what? All the changes I did on that curriculum actually saved us on accreditation because we were going to get murdered if we haven't done that. Right? So it was like those things meant to be. And then over the years, of course, my research has always been on imaging and endodontics, particularly small field of view. I wouldn't say it started with endodontics, it just started with high resolution CBCT imaging. But, you know, in the beginning of my career, there were the early publications at the JOE and that kind of stuff. Until I had the chance to finally speak at the AA for the first time in 2011. It was a fall meeting in Vegas, and I went there. The title of my presentation was 50 Shades of Gray, right? 56 Shades of Gray. And everybody was like, oh my God.
I remember that. I was in one of, it was either 2011, 12, whatever, but I remember taking that class, the 50 Shades of Gray.
50 Shades of Gray. Everybody was like, wow, that's funny because that was on everybody's kind of culture radar at that time. And it was interesting because I was the first radiologist that came in front of an audience to promote imaging, not to scare you from radiation, not to scare you from stuff that you didn't know, but to say, guys, what are you doing if for not using this? Are you insane? You gotta use this. So I've always been that engine moving the specialty, the diagnostic part forward with imaging. I never in my lifetime try to block you from using. I'm trying to find every excuse in the book to make sure that everybody has access to this technology, use it properly, and help their patients. Like you said, you're a big believer of understanding from the inside out of what's happening with the tooth. You can't do that with two-dimensional imaging. And all the research, everything is showing people is like, well, yeah, you don't. So we gotta use this. And the interesting part is after that lecture, of course, I start to get invitations to speak more and more and more, and I became this well-known person within the American Association of Endodontists. And I would finish my lectures, right? I would be, at the AA somewhere or finish a lecture. Then I would be walking around and people would stop me and say, Bruno, you're the cone beam guy, right? Let me ask you a question. And then over the years, this would repeat, I kid you not, about 50, 100 times per meeting. Bruno, you're the cone beam guy. Let me ask you a question here. And then people, of course, they're asking me, what is the best machine? What should I buy? Or whatever that was.
Right.
And I started to realize, I was like, you know what? Screw that. I'm the cone beam guy. So I'm going to take this nickname. I'm going to own it now. So that's how this cone beam guy started. And then, I have dedicated my academic career towards, again, building curriculum, but also trying to figure out ways to explain folks how to properly use this technology. I think cone beam CT imaging is a technology that's very forgiving. And let me tell you what I think that is. Everybody here knows, every dentist will know what a periapical radiolucency looks like, right? So if they can barely see on a PA, but then they take a cone beam, it's very visible. So you don't need much training to understand, there's something here at this apex, or there's bone loss here, or this canal is curving that way. It's very forgiving right away. So the problem with cone beam is not what you know, is what you don't know that you don't know. That's the biggest challenge. And then when you think about folks that invested on this technology, it's the only piece of equipment they own that they were trained by the least qualified person. So when you think about training that most general dentists and specialists have, they bought a unit, right? They never had these lectures in dental school, or they have something very, 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 subpar. And then who trained them? Who trained them was the folks that installed the unit. So there's an engineer somewhere, or a salesperson somewhere.
Right, basically like for ours, like a sales rep, yeah, that just was trained on the unit. Yeah,
Correct. And
yeah.
that's your training. So now you have the
Mm-hmm.
most expensive piece of equipment you own, and you have no training, or the training that you had is done by the least qualified person as possible to do that training for you.
Mm-hmm.
And but again, because it's so forgiving, you're like, oh my God, look at what I can see, look what I can do. This is great. And you stumble a little bit and you can use it. But then when you realize what you don't know, that's a whole other universe in there. And that's kind of like what my space was I'm going to try to show folks how to, number one, how to proper use this particular technology. And then number two, I'm going to enhance your game. I want to make you a better dentist without teaching you nothing about clinical dentistry. All I'm going to do is
Mm-hmm.
teach you the diagnosis start that most people don't know.
Mm-hmm.
Because
Mm-hmm.
again, you don't know what you don't know. So because
Mm-hmm.
of that background of how to break down knowledge, I was able to figure it out a way to finally teach imaging in a
Mm-hmm.
sequence. So I came up with what's known as the 6 pillars of imaging. That's kind of like how I
Mm-hmm.
teach my courses and things like that.
Yeah.
The 6 pillars of imaging is like you dissect imaging, like exactly what I did with curriculum, create the pillars and say from each pillar here, this is what you need to know. So
Mm-hmm.
when somebody comes with a question, typically the question is, Garth, oh, Bruno, how do I look for a fracture? That would be the first thing they're going to ask me, right? Like in endodontist, the hardest thing there is to do
Mm-hmm.
from a diagnostic perspective. Well, how do you know this? How
Right.
do you differentiate X from Y? And they want what's called the fifth pillar, which is the interpretation pillar, but they don't know the fourth ones. So what are the
Mm-hmm.
6 pillars of imaging? Pillar number one is our computers. Tell me what you're
Okay.
using for your computers, what your screen, what computer you're using, what is your network. Are you using TVs? Are you using monitors? There's so many variables that will
Mm-hmm.
influence how fast, you know, how agile your practice is going to be
How
just
many
based on the
pixels,
computer
all that kind of
networking
stuff.
alone. So you
Mm-hmm.
master the computer network. Okay, great. If you invest $50,000 on a computer on a machine, and you could invest another $8,000 to beef up your computers, again, you're losing money there because everything's going to be slow or it's not going to run the way you think it's going to run. Cone beam CT imaging and computer networking and hardware, they go hand to hand. Um,
Mm-hmm.
After you go from acquisition, you go to me to the most important of the pillars, which is the acquisition pillars. Most dentists that are listening to the podcast that own a Cone beam CT scanner, they cannot answer a simple question about their scans, which is what were the parameters of the scan the last scan that you took? What was the KV? What was the MA? What was everything? They don't know.
Mm-hmm.
So if you don't know the KV of the last scan that you acquired, if you don't know the MA of the last KV that you acquired, you don't know the resolution, the acquisition time, you have no idea what the capabilities of that scan is from a diagnostic perspective,
Mm-hmm.
because each one of those parameters will make a difference. For example, if I can see a vertical root fracture or not, right? And
Mm-hmm.
and what is it everybody does? Everybody has a cone beam CT that was put together by, like I said, a sales guy or some engineer from the company, and all they do is use the presets that the machine gave it to them. So it's like having a
Mm-hmm.
Ferrari and put it on drive and driving at the same speed the whole time. Sometimes it works, sometimes it doesn't.
Mm-hmm.
You need to learn how to use the stick shift part to really
Mm-hmm.
take that car as fast as you can. Um,
Mm-hmm.
so the acquisition part to me is the most important component of a 3D imaging system, because that's going to determine how well your interpretation is going to be. Does that make sense?
Y- just on that note, because and I know it's probably a day lecture just on that. You could go into detail, but just like if you were to say in general, somebody's got a comb beam machine and they're trying to get it improved, like a 2 minute. This would give you the biggest bang for your buck if you did X, Y, and Z with the EMA or KVP, or, or,
Bump up
or where could
everything.
they find
Very
that kind of
simple.
info?
Bump up everything.
Okay,
Bump up everything. Everything.
got
If
it.
you bump up everything, you're always going to have the best image quality. It's simple as
That's good to
that.
know.
Um,
Hmm.
the other thing too is there are many secrets that I teach in my courses. If you look at any brochure from any manufacturer, right? You look at whatever you want to buy a machine, they're going to give you a brochure. Here's a brochure that tells you about this machine, blah blah blah. What do they all have in
Hmm.
common? What they all have in common is who is the patient on the machine. It's always a
Mm.
supermodel with the longest neck
Yeah,
that you will find on a human being in a perfect smile,
yeah,
right?
yeah.
So you can position those patients very, very, very easy. You know me personal. I'm a 6'4" guy. I'm 300 pounds. I have really broad shoulders and almost no neck. Try to position
Yes.
me on those units and see what happens. That machine starts to hit your shoulders. Or, we
Yeah.
working in the dock.
Good for jujitsu, but bad for getting a comb beam, right?
Absolutely. Right? You can't choke me out, but it's really hard for me to
Yeah.
get my I have an 18 and a half size neck, so it's you can kind of
Yeah.
it's pretty big. Um, so imagine that we in endodontists we see people that are teenagers all the way to the 98-year-old great grandmas out there with a hunchback. So the question becomes, how do you image that person? I can image the supermodel, but now if I have somebody here that's elderly, hunchback, that's hitting their shoulders, how do I do that? So you have to understand the acquisition process really well. The moment that you acquire the image, um, now you have to correct the image. And in order to correct the image, you have to understand what you're correcting for and why. So you correct the image, that's pillar number 3. Now we go to pillar number 4. How do you navigate the data? What are the tools that I have to navigate the data? Because everything is dynamic. If all I do is do one size fits all, you're missing out stuff. So you go, how do I navigate the data? How do I slice and dice? What are the tools that I have? And then what sequence should I use this for to make it faster, better, meaner? The moment that you understand those 4 pillars, now we can talk about interpretation. Now I can talk about the patterns of imaging that you need to learn. What this means if this is perforating bone, expanding bone, it's doing this, X, Y, and Z. And then we can now start going diving deeper into the finesse of imaging. But again, you already have your computers there. You already acquired the image it's a proper acquisition for your diagnostic task. You know how to correct the data. So if there are artifacts or it's too bright or too dark, you know how to fix it. And you know how to use the tools to slice and dice the volume to enhance whatever diagnostic task you have. Then you got your interpretation. And now we have the 6th pillar. After you did all your interpretation, now comes advanced technologies. It's how do I get this data now, and I can use it for surgical guides. I can use for dynamic navigation. I can use to do some segmentation and go to 3D printing. And if you follow this sequence, you're going to master everything. But if you just try to say, oh, I'm just going to take a course on this, and you don't know the other pillars, that's it. You're fish out of water. So it took me years to really figure it out, what the sequence is and how to put it together in a systematic approach that makes sense and connects all the dots for you. And in a lot of my courses, the first, I typically used to teach the 2-day course, as you know. The first day, I'm not teaching you how to do any interpretation. It's all about the first 4 pillars. And people are like, man, I paid for this course and I didn't learn anything about how to read the fractures yet. And then suddenly they go to the next day and they go through and then just clicks and they go like, oh, this is how it works. And one of the things that I used to do that was pretty fun, I would always start my courses, my hands-on courses, with one case, and I say, go ahead, do whatever you want. I want to see how you read the case. I want to see how do you describe this, how you do all those things. And in the end of the course, after 2 days, I would give them the same case. I say, go back to that case and read it again. And the whole time, all you hear is goggles. People like, ha ha ha, ha ha ha, like all the stuff that they missed and all the stuff that was wrong. It is just so funny to see like the huge light bulbs in the room going like shining. It's just awesome. So we go, okay, so now you are on the path that you can, move on and just continue like this. And that's also very important is to whatever you do is to always have a systematic approach to it. And that's one of the beauties I think about our specialty, right? Endodontics. We are very systematic on the way we do things. There are little variations and so on that we have to apply in our daily cases, but we tend to follow a very simple kind of systematic approach that works every single time, which is exactly the same thing with jiu-jitsu. You have your top game, you always go towards and we hear a lot of this saying in endodontics, which is you take what the canal gives you. What is it we do in jiu-jitsu? You take what your opponent gives you. It's the exactly same thing. So that mindset is there for us the whole time. And in imaging, it's no different. You just follow that systematic approach, and typically that will bail you out, or take you out of trouble.
On that note, and you know this about me, but I did a church service mission in Brazil, lived there for 2 years, loved it. And saudades. I mean, I miss Brazil and the food and everything else, the people there. But it was I first saw jujitsu there, and I didn't even know what it was. I thought it was like judo because they had the
Yeah.
thick gi, and I was like, man, if I could ever get a chance to learn that, I'd love to. And when I was in Indiana, my last year, a blue belt started a school, and I'm like, hey, this let me try this out. The UFC was just starting off, and ended up learning it. I actually got my blue belt from Hoist Gracie. It was back in the 2004, so like
Wow.
early start of jiu-jitsu in the US. Like it was, I'm sure for decades was around there in Brazil, but yeah, it was early in the US. So that was kind of cool to get my blue belt from an OG from Hoist Gracie. But very few times in my life when I had like literally like a mind shift, and learning jujitsu was one of them. As far as just using leverage, uh, it's like human chess. You have to think at a different level because you can't go, I'm going to do this and I'm going to do this. It's like, no, no, no. You have to do, you can only do what's coming your way, And so you kind of learn, uh, and you can. I mean, you could probably do something just because you want to, because you're such a big guy. But in general, the beauty of jujitsu is you take what your opponent gives you, and then you can use it against them.
Yeah.
And so there's always there, and so that makes a ton of sense on how you broke down those six pillars of you have to have that understanding, and you have to have a sequence of how you're going to approach every problem that comes, every image, every patient's issue that comes your
Sure.
way. So that makes a ton of sense.
Yeah, I mean, it's no different than, let's say, auto surgery. So I was in a big
Mm-hmm.
trauma center in Louisville, level 4 trauma center. So that was my department. My boss was an auto surgeon as well.
Mm-hmm.
And I was doing all those images. So imagine like somebody would come in and half of the face is missing. And your initial approach is, man, just let this guy go because we can't
Mm-hmm.
do this. But no, it's like you see the mass of a puzzle. You find the first piece that you want, and then you find the second piece, and then you start to put it back together. Everything is
Mm-hmm.
in life is going to be very similar to that approach. No matter how messy the situation is, you have to
Mm-hmm.
kind of step back and follow the sequence. And if you believe that your systematic approach works, you get off the
Mm-hmm.
pickle. And
Mm-hmm.
it's the same with imaging. A lot of times people get very frustrated or afraid because they will see something that looks scary or looks out of place. And instead
Mm-hmm.
of trying to figure it out, how to describe it, what is it doing, and patterns, the first thing that comes to mind is they try to immediately come up with a diagnosis. And that's the wrong
Mm-hmm.
approach to imaging. Like, the last thing
Mm-hmm.
I'm doing, no matter what it is that I'm doing or looking at, it's trying to figure out what the differential diagnosis is. I look
Mm-hmm.
at something, my first thought is, okay, how do I describe this? And then you start
Mm-hmm.
describing and picking up features and understanding, again, going for the whole systematic approach. And then you start to
Mm-hmm.
put down on paper what you saw, what you've seen. And interesting enough, um, differential diagnosis has a very sort of a computational power associated to it. As you imagine that you
Mm-hmm.
start every case with every single lesion there is in the human body. And the moment that you
Mm-hmm.
start describing, you say, okay, I see one. Everything that's multiple falls off the cliff. And you say round.
Mm-hmm.
Everything that's irregular shape falls off the cliff. And you say well
Mm-hmm.
defined. Everything that's ill defined falls off the cliff. And then you say corticated. Everything that's non corticated falls off the cliff. And you say radiolucent or low density. Everything that's radiopaque falls off the cliff. And you start doing, every little thing that you say. You started with everything, it starts to narrow down. The funnel starts to narrow down. And by the time you add
Mm-hmm.
who the patient is, what are the clinical symptoms and things like that, you're going to be left with 3, 4 options. And then what is it that you do? You pick the option that is the most common one as your number one differential. And then what's the second most
Mm-hmm.
common one? This is this. And then the third one, this is that. And the fourth one, this is this. There are
Mm-hmm.
times that it's so obvious that it's pathognomonic. So I'm very well known for being a radiologist that I don't stay on the fence too much. I tell you what it is.
Mm-hmm.
Oh, this is this. Don't even
Yeah.
bother. I don't like too much.
Mm-hmm.
There's a lot of times that my colleagues writing reports, they tend to be a lot on the fence. I'm like, no, this is what this is.
Yeah.
Because in the end of the day, that's
Mm-hmm.
what you want to hear from me. You don't want to hear like,
Right. You
oh
want
yeah,
what?
correlate this with clinical symptoms, and now you're on your own. It's like, no, I want you to be the voice that pushes me on a certain direction. Because ultimately, in the
Mm-hmm.
end of the day, we're going to have
Mm-hmm.
to have a decision on what to do, right? Uh,
Mm-hmm.
and when you,
Well, just on Comey, like for we got our cone beam in
Yeah,
2015, and we were the first in our area to get it. So a bit of a pioneer, but still, it was around for a while longer. My biggest regret is not getting it
sure.
sooner, just because of a game changer it was in our practice. How you could go, especially in endo. I mean, as a general dentist, it may or may not make sense, but for what we were doing, it was a total game changer to go from wondering, is there an MB2? Is there a fracture? Is it, you're doing a retreat with a cone beam, there's no guesswork. It's like, oh, there it is.
Yeah,
You can see the MB2. You can see the vertical bone loss. At least I may not be able to see the fracture, but I can see the vertical bone loss. And just with diagnosis, with it really was a game changer. And even as far as clinical wise, it felt like I was cheating because I knew what I was getting myself into before even getting in the tooth.
yeah. It's a good cheating part, um, and I can't think of another uh, medical specialty that would have what you just described. You almost feel guilty by knowing. And,
Yeah.
and I don't know where the mindset comes in dentistry where people say, oh, this is cheating, or no, this is too easy now. It's like, what do you mean? Like, if you had a heart doctor treating you for a heart
Yeah.
disease and you had something
Mm-hmm.
that changes diagnosis in 62% of the time and it
Yeah.
makes them more predictable in whatever they're going to do, you'll be begging for that
Mm-hmm.
doctor to please use that on me,
Yes.
right? That doctor would
100%.
have no hesitation whatsoever to say, "Hey
Mm-hmm.
guys, I have this tool here that really shows me what's going on, but traditionally we use this. So what do you think? Should we stay or should we go?" There's no discussion.
Mm-hmm.
This is something
Mm-hmm.
that, again, I try to fight the whole time. It's like, don't feel bad for being part of a
Mm-hmm.
generation that has tools
Mm-hmm.
that if the
Mm-hmm.
grandfathers that gave us the foundation to do what we do today had access to, look behind me. Just
Mm-hmm.
look behind me,
Yes.
right? So
Mm-hmm.
so imagine
Mm-hmm.
if Dr. Haas had access to 3D imaging back in the day. This guy knew this was going on. All right, he was trying to figure
Mm-hmm.
it out stuff. And imagine if you had access
Mm-hmm.
to cone beam, micro CT. Ah,
Mm-hmm.
we're
Yeah.
literally just scratching the surface. There's a lot that we know,
Oh,
but there's a lot that we don't know, and we're trying to figure
you know,
that out.
just on that line, because I know some people that don't have cone beam, and even some patients, their concern is, well, I don't want to do it because of the radiation,
Sure.
the exposure, and I know I know what your answer is going to be, but just so everybody understands, if you could speak a little on that, on the risks of cone beam versus the benefit, as far in terms of exposure.
Sure. So what I like to do when I'm with an audience of doctors, okay, I always ask one simple question: can anybody tell me one risk of imaging, of dental imaging? I just want to know one, and what would that be? So if I were to ask you right now, can you give me one risk?
The radiation exposure. At least that's what they're going to say.
Risk of what? What is the radiation exposure
Yeah,
doing?
good point.
So here's the thing. Nobody can give me that answer because the answer will be,
Mhm.
oh, risk of cancer. I was like, well, no,
Mhm.
because again, we're all doctors here. Can you explain to me how
Mhm.
dental imaging, the energy that's generated from a PA or a pen or from a cone beam, can interact with the human body that can lead to cancer? Just think about this. Like as a doctor right now, with all the studies that you had throughout your lifetime, could you explain
Mhm.
this to me? And the answer is no, you can't. Because there's no way to explain it,
Mhm.
right? It's all based
Yeah.
on theory. So the whole idea
Mhm.
here is that unfortunately we were pushed a lie over the years. And that lie is
Mhm.
called the linear no threshold theory, which says that there's no safe exposure. The only
Mhm.
safe zone is zero. And the moment that you have some level of exposure, now there is a greater chance of the detriment effects of radiation. And that effect is linear, meaning that, if you have something that is 100 versus 50, 50 has 50% less risks because of that. So that's where this whole paranoia of imaging comes from. But what
Mhm.
we have proved beyond reasonable doubt over the years is that there is a safe zone uh, radiation exposure that has absolutely no harm to humans. Okay, and how do I
Mhm.
know this? It's very simple. Where you are in Washington and where I am in
Mhm.
Philadelphia and where somebody is in Utah or somebody is in Colorado, just by living there, the radiation
Mhm.
background levels are fundamentally different. But if you look at homogeneously around the globe, um, the levels of cancer, the levels of mutation, they're pretty much the same across the board. Because you live in Colorado. Colorado, it's much higher in altitude. The population there is definitely healthier than people in Alabama, for example, right? They're actually on the outside. They're actually enjoying that extra radiation. They're outside. They're hiking and doing exercise, and they're not getting 3 years because of that. All right, but the radiation levels that they receive there is fundamentally higher than other parts of the world. So, and then the whole idea here is this fear, this fear of the unknown. And the fear of the unknown becomes a problem because somehow, somewhere, that fear becomes more important than the information that you just described. The information about how important it is to understand the microanatomy inside that tooth, where bacteria is hiding and is creating all those things that is destroying the bone around your tooth. It's putting stress, pain, all those. It's overloading your inflammatory, your immune system. This is what causes you harm. It's not the imaging that's going to allow me to treat this for you. You know what I mean? So there is this. We have to reverse the question. So the first thing I do when patients come talk to me about this, I have never ever engaged in risks. I don't use the word risk at all. My job is to explain to the patient what the benefit is going to be without even going on risks. I'm going to explain this is going to allow me to see the microanatomy inside the tooth. This is going to allow me to see where the bacteria is hiding. That's our enemy. That's what's creating the pain, the swelling. This dark area here at the apex of your tooth. Um, let's find those together, because when I'm in there, I'm going to wage war at that bacteria, and we're going to heal you, okay? Or I'm going to train the surgery, or whatever it is that I'm going to do. So it's all about the benefits. Interesting enough, let me just give you an example. Let's say that you have a patient that's now mad at you. Oh, you're going to take a 3D image of my tooth. How dare you? And that patient is storming out of your practice, angry with the world. And unfortunately, that patient gets into a car accident. What are they going to do to that patient? They're going to rush that patient to a hospital, right? And guess what they're going to do where he or she gets to the hospital? They're going to get imaging head to toe. It's a trauma,
A million
right?
X-rays, yeah.
So, okay, the patient is like, imaged multiple times, something broke, whatever. You spend a week in the hospital, now you're leaving the hospital. As you leave the hospital, you get distracted again, you got in another car accident, and you got rushed back to the hospital. What do you think is going to happen when you get there? Are they going to say, oh my God, you got 3 CT scans last week, I can't do this anymore? Or what do you think is going to happen? The same thing is going to happen.
More images.
And next week, you come out of the hospital, you're such a bad driver, you're in another accident, you're back again. What do you think is going to happen? More imaging. So this cycle never ends. There's no such a thing goes, oh, I already had all the maximum radiation I've had in my lifetime. No, it's whatever you need on that moment, okay? Because if something happens, that's how we're going to manage it, regardless of how many imagings you need or you had in the past. If you need it on that moment for whatever the heck reason, we're going to do it to you. Just like if you were to a hospital, you're going to have no option to say, hey, I don't know if I have a concussion, I don't have a bleeding inside my brain, I have all those symptoms here. I'm not taking a CT scans. I'm too afraid of radiation. No, you go in, and they're not going to even give you that option. You're just going to go and do it. So we just have to get better in explaining to our patients this. I think every time that there are papers that talk about risks without never explaining what those risks are, and this is one of the lectures I gave at the AAE years back, where I was quoting all those papers from folks that are not radiologists, have no background in radiation biology or radiation physics, talking about, oh yeah, by the way, you always have to weight the risk versus benefit. Like, for freak's sakes, just tell me one goddamn risk. I mean, I'm sorry that because I got passionate about this stuff. I was like, no, just tell me one freaking risk here, because you don't have that. You really don't have that. And then now let's talk about the benefits, by the way. Because all these things here can save lives. I cannot tell you how many cases of lymphomas I have in my database of real, bad stuff that's being perceived as endodontic lesions. That suddenly look at those patterns, they don't match what I would expect to see on your apicoperiodontitis. Let's get a biopsy here. It turns out to be cancer. Now you're literally saving that patient's life. That is a completely different story, right? So Garth,
We had a patient come with multiple myeloma. She came in for retreat, a lesion that wasn't healing, and it was like, this does not look like a endodontic lesion. Sure enough, it was multiple
There you go.
myeloma.
So we
Yeah.
all have those cases, and you're going, all right. So now I'm saving your life. I'm not putting your life at risk.
Hmm.
So um, we need to, in one way or another, start rebuilding rapport with our patients, where there's a lot of trust in what we have to say. Um, the challenge with imaging today is that I'm changing the way I explain imaging to endodontists. I don't want an
Hmm.
endodontist to use the word cone beam anymore. I try as much as I can, at least in my practice, not to use the word
Hmm.
cone beam. I think
Hmm.
the word cone beam is too generic. We need to differentiate ourselves a little bit more, because what you do from imaging in your practice to have the resolution that you
Hmm.
need to see, again, the microanatomy behind the vertical root fractures, that kind of stuff, it's not the
Hmm.
same resolution that the oral surgeon is using to do a full head cone beam for orthognathic surgeries, or the prosthodontists and the periodontists are using for dental implants. They're fundamentally
Hmm.
different. So what is the problem that we're having right now? The problem that we're having right now is that you have patients that went to a general dentist, and of course, general dentists need to have this technology in their practice. But the
Hmm.
way they scan patients, remember, pillar number two, it's not appropriate for the endodontic diagnosis that we do. So therefore,
Hmm.
they burn a CD, they put it on a pen drive or a CD for the patient. Say, oh, I already took the cone beam. Take this to your endodontist. He will use it. And that's a false equivalency, right?
Hmm.
That 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 scan, number one, it's just an image in time. Maybe it was 3 weeks ago, 4 weeks ago. Doesn't represent what it is today. And number two, most of the time, I would say 99% of the time, it doesn't have the features that I want for an appropriate, what I call an appropriate endodontic diagnosis. So
Hmm.
now the patient is fighting with your front desk and seeing us as mercenaries. It's like, no, 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 you just want more money. And, it becomes this money thing, where in reality it has nothing to do with money. You just say, you know, this is not appropriate. You cannot try to use something that's not going to help me, or is going to give me subpar information. So we are now becoming very picky about um, what 3D imaging endodontics should be. So what I like to say is, like, well, we don't do cone beams. What we do here is enhanced. I'm sorry. Endo enhanced advanced imaging. So endo enhanced advanced imaging. That's what we do. And what is
Endo
the
enhanced
and
advanced
what is the
imaging.
difference between endo enhanced advanced imaging versus cone beam? The cone beam that your general dentist took, or your other dentist took, told us that you have a problem. There's a problem there. We're able to pick up. My endo enhanced advanced imaging is going to tell us what the problem is, what the source of that problem is, but also is going to tell me what is the microanatomy associated with that. And that's what
Hmm.
I need to treat. And
Hmm.
interesting enough, what you see here, this is the art that's going to be hanging around my practice. My
Hmm.
whole practice, all the rooms, the whole thing. All I want is it's like micro CT, Dr. Hat's teeth, because I want to point out this to patients. This is what it looks like. It's not a tiny little canal. I have all
Hmm.
those little channels there. The bacteria is hiding, and I'm
Hmm.
explaining them to them,
Hmm.
and they get it. They go like, oh, I understand now. Yeah, I say I need to see what that little line is. This CD here only tells you that you have a lesion. What is going to really truly
Hmm.
allow me to see that microanatomy right there is if I use endo enhanced advanced imaging. They're two different things. And patients typically
Hmm.
understand this really well. When they are explained the reasons why, they're like, oh, I get it. And then,
Hmm.
um, it's a very good way to explain this to a patient, and then even later on to your general dentist, whenever you have a chance to,
Yeah.
study on, speak on your local study club and stuff like
On
that. Just go over that with them.
Hey, on that note, because we've got general dentists that are part of lifestyle dentists too. How would a general dentist word it? Do you think that would be a good way to word cone beam that would be helpful for
So I think the
a
general
patient in a
dentist, what
general
they're
dentist
really
office?
doing, it's coming up with the first diagnosis, is what I explained before.
Hmm.
They're going, there is a problem here. Okay, so
Hmm.
basically what they did was they are the witness of the crime. They found something. It's like, oh my
Hmm.
goodness, there's a problem here, and you're in pain, and this, and this is great. We have this technology that allows us very easy to see there is an issue. I need you now to
Mm-hmm.
send you to the detective that's going to kind of try to solve this problem here. The detective is going to have to, which is you now, right? Is going to have to go in there
Mm-hmm.
and figure out the crime scene. What is it that I'm suing? What are the clues? What do I have? And based on our training, you figured out what that is, and we're now going to go for the treatment. And if we are in
Mm-hmm.
doubt, now we have to go in and involve the pathology people. The pathology people are the lab people. They're only going to say, well, I have
Mm-hmm.
this lesion here. Like you said, you have the multiple myeloma, right? And you're thinking,
Mm-hmm.
I wonder who committed this crime. Was it A, B, C, or D? And then you take a
Mm-hmm.
sample of that, send it to the guys in the imaging lab. They find the DNA, they match the prints, and they go, you're the this guy is the guilty one. And how do we deal with this guilty one? And off we go.
Mm-hmm.
It's almost like one of those cop shows, but everybody has
Mm-hmm.
their role. If you're trying to get the witness to be the detective,
Mm-hmm.
sometimes it works, sometimes it doesn't.
Yeah.
Sometimes it doesn't.
Yeah.
It
That's
is
a good
what it
point.
is. I think there's a reason why we do what we do at the level that we do, and
Mm-hmm.
not every general dentist out there is going to refer patients to endo for whatever reason, and I respect that. I think if you want to do
Mm-hmm.
this and you like doing it, that's why you're a general dentist. You can do whatever you like. Uh, but there are times that if you understand certain features, if you understand how complicated things can turn very fast, you
Mm-hmm.
you have to think what's best for the patient, right? Is it better
Mm-hmm.
to be managed by
Mm-hmm.
somebody that only does this thing for a living and has a lot of experience on the diagnosis and the treatment and the management of whatever complication may arise from this?
Mm-hmm.
If that's the case, if what's best for the patient is to refer it out, please do it.
Mm-hmm.
You know?
Mm-hmm. Yeah. And I even think, because I talk to the friends that are general dentists and uh, anybody really, any dental specialist, anything you do to understand what you do well and you enjoy and you can do predictably and do a ton of that. And whatever else, if it's not predictable, if it's not something you enjoy, refer it out. And that's, I think, the most successful general dentists that I know in our area, that's what they do. They're great clinicians. I mean, they can do endo, they could do wisdom teeth, they can do implants, they can do a lot of things, and some do some or all of those areas. But the best ones that I know, they don't do everything because they're smart. They know what their time is
Yeah.
worth, and if they can do 3 crowns the same time it would take them to do one endo or uh, wisdom teeth where they've had complications and dealt with all kinds of problems because of the complications. They just know to choose your battles.
Yeah.
It's like I was a general dentist for 2 years. I haven't done a crown since 2005, not even on my own wife or family members, just because I know I'm not as good
Sure.
as a buddy down the street that does it every single day, day in and day out.
Yeah, I totally agree with that. And I get I get frustrations on both sides now because I get the frustration on imaging, and I'm
Mm-hmm.
watching people going like, man, this case should be referred out. At least have a second person take a look in there, or learn how to do this
Mm-hmm.
properly. And that's the radiology from the radiology side and diagnostic side frustration, I would say. And now a little bit on the endo side,
Mm-hmm.
it's like, maybe you shouldn't have started this because now it's
Mm-hmm.
something could have managed a little
Mm-hmm.
simpler. Now it's a little bit more complicated. But regardless of the
Mm-hmm.
politics of the games or and so on,
Right.
um, what people
Right.
need to know is that you don't need to force yourself to do
Mm-hmm.
something out of your comfort zone just for the sake of doing it. There,
Mm-hmm.
there, there,
Mm-hmm.
there, there are a bunch of people like us out there that's willing to help you, guide you, see your patients.
Mm-hmm.
I know what you did in the beginning of your career. Again, I was listening to your podcast. You, you were you were using the four magic words in endodontist, which is send them right over. Right, it's never a no.
Mm-hmm.
Let's keep working and helping patients.
Mm-hmm.
I feel that uh, everybody out there in the healthcare industry has a higher level of compassion, even though some are perceived
Mm-hmm.
as business people and so on. But there was a level of compassion in our profession,
Mm-hmm.
and um, if you just obey by this rule, do what's right for the patient, uh,
Mm-hmm.
you'll be
Mm-hmm.
very successful, no matter if you're a general dentist or a specialist. And in
that's
as a
a great
specialist,
point.
I'm a strong believer, strong believer, that to do what's right for the patient involves um, imaging. So you never
Hmm.
let the patient dictate treatment. Oh, I don't want imaging. I don't want 3D imaging. I'm afraid of the radiation. So no, you flip
Hmm.
the script. One of the little tricks that I tell my students is like, how many fingers you see here? How many fingers you see here? No,
Two.
three. That's why I need that third dimension, right? So,
Good
so it's
point.
it's a very simple little trick that I
Good
do
point.
um, with patients, and they understand it. Um,
Hmm.
I have one of my courses that I teach online. I actually go through the whole script on how do I make patients self-diagnose in 30 seconds. So, which is really
Hmm.
interesting. I have this whole routine where um, over the years I have developed now that I'm back into clinical dentistry that I'm not the one diagnosing things. I'm having the patients diagnosing
Hmm.
themselves. I'm just guiding them, and they're the ones going,
Hmm.
"Oh man, what's that?" And then, "Oh, that's bad. I don't want that. Yeah, let's do this
Hmm.
root canal like now." It's really interesting. It works great. So there are things that you can do to you know kind of explain what you're doing, make the patient understand, appreciative of what you're doing for them,
Hmm.
and then from there is just your talented to go and manage it. But the
Hmm.
diagnostic part that typically historically has always been kind of uh, uh, like an Achilles heels for most dentists. I think with the technology that we have
Hmm.
today, it's quite the opposite. It's,
Hmm.
it's, it's the better, faster, meaner one. Now it's only your hand skills that
Hmm.
you have to rely on. Diagnostic skills,
Hmm.
I think we are now in an era where the future is going to be bright. There's going to be a lot of AI coming up to help us. And the interesting thing is you're gonna rely less and less and less on guys like me in the future, but but you are still going to have some sort of library of knowledge to be able
Hmm.
to use the newer technologies and new developments in AI software, that kind of stuff, to really bear you out. There's a lot of noise, a
Hmm.
lot of frou-frou stuff out there that I'm going like, this makes no sense to me. Uh, but there are some ideas bumping up that uh, um, that I even hope to be part of some of those projects that I think that
Hmm.
it will definitely enhance the game as we move forward, and
Yeah.
enhance it in a way that's just not something that's white now showing up as pink. I don't believe in that, but stuff that can actually be
Hmm.
meaningful for treatment planning
Yeah.
and diagnosis.
Yeah. A quote I heard that made a lot of sense on AI is not going to take your job. It's going to be somebody that knows how to understand, or they understand and can apply AI would take your job.
Yeah, for sure.
you
Yeah,
know, I mean, it's just a technology. It's just a tool like anything else. But if you can apply it, that's
yeah,
powerful.
yeah. So the application, and it's powerful. And it's like what we were talking right before the show. We were talking a little bit about advanced irrigations and some other things. One
Hmm.
of the things that I wrote in one of my papers that kind of people quote me on their slides is, access to technology does not translate into proficiency in technology.
Yeah,
And so
that's a good point.
that's my claim of fame, kind of like stuff that I wrote.
Yeah.
So yeah, you can have access to AI or whatever it is. It doesn't mean that you know what you're doing and you're proficient at it.
Hmm. Hmm.
Like access to cone beam doesn't mean that you understand what is going on, or access to a laser or a gentle
Hmm.
wave or the latest fire or the latest cement or the latest bioceramic. It requires
Hmm.
knowledge. It requires a deep level of understanding of what's going on. So AI will never
Hmm.
be able to bail
Hmm.
you out, because if you're giving all this
Yeah.
information up front but you don't know what to do with it, it doesn't matter.
Hmm.
That's the
Hmm. Bruno, I can't believe we're at an hour and 3 minutes. I can't believe that we've gone this long. This has been amazing. Seriously,
my
this has been
pleasure.
such an awesome podcast, and I definitely need to have you back on because you're just a wealth of knowledge. I mean, we could talk for hours.
Everything is done by
I
design. I
did
told
want
you, we
to.
start talking and then boom, goes by pretty fast. It's like, where did that time go?
It's so true. I wanted to cover a couple things just before
Sure.
we wrap up because you've done so many amazing things with as an oral radiologist with the cone beam guy, your training program. Now you're finishing your endo residency at Einstein. You only have a couple weeks left what's next for Bruno Acevedo and uh, those that would love to learn more from you? What's a best way for them to reach
Yeah.
out?
So what I did was I decided that I was going to be my own boss and be a little bit more entrepreneurial in this space. There's a lot that we're going to
Mm-hmm.
talk later because I need to learn a lot of the business side, the business mindset from you, um,
Mm-hmm.
which is the fact that,
Anytime.
all my life I was in academia. I was, of course, a speaker going around and doing those courses, but it was never truly a business. It was just part of my academic kind of a lifestyle. Um,
Mm-hmm.
Going through residency before I started residency, I had a huge doubt in my mind. I was like, I'm going to start something that I have an idea what it is, but I haven't practiced dentistry or clinical dentistry in 22 years. I really need to know, can I do this? And
Mm-hmm.
the moment that I figured out that I could, and the moment that I figured out that the background that I had would actually be an asset to what I was doing,
Mm-hmm.
and just because, through my life history, I've been a problem solver. I'm the type of guy that can look at things, and just the way my brain works and everything I was explaining to you, I look at things a little bit different than most people would, and I can break it down and say, okay, this works, this doesn't work. That is what excites me. Um, I decided that I was gonna open my own practice, and it was gonna be
Mm-hmm.
different than any other endo practice that I know. You will
Mm-hmm.
have all the technologies that are out there, but also the technologies that I'm currently developing. So there are
Mm-hmm.
new things and new protocols that I have learned, and I'm doing it. And for the first time
Mm-hmm.
in my life, I can keep them a little bit secret, which is great because it will allow
Mm-hmm.
me to differentiate
Mm-hmm.
myself
Yeah.
from other folks in the area that I'm going to. But at the same
Yes.
time, it will give me the opportunity to continue my mission on the academic side. So when I
Mm-hmm.
was trying to figure it out where to go, I actually hired a company called Doctor Demographics. I'm not endorsing anyone, but this is what I did. Doctor
Mm-hmm.
Demographics was a company out of Utah. Those guys have been doing demographic studies for doctors for over 40 years. And
Mm-hmm.
I hired them up, told them my story, told them who I wanted, who I was, and what my vision was. And those guys scanned the United States and came up with locations where they said, well, this is where there's growth. This is where your profile fits the culture of the area, and
Mm-hmm.
and then this is how many doctors are there, and the whole demographics. Where are the patients? Where this? Where's that?
Mm-hmm.
I told my wife, listen, those are the options that we have. You pick and choose. And the winner was Austin, Texas. So I'm
Awesome.
moving to Austin, Texas now in the summer. My family's been there now for about a year and a half. So I've been
Nice.
doing my residency program by myself, which was a
Mm-hmm.
curse and a blessing. I sacrifice the present of being with my family for the future that I'm going to be able to
Mm-hmm.
provide to them. So for the past 2 years, I've been living
Mm-hmm.
away from my family. It's been tough. Not easy at all. I
Mm-hmm.
have
Oh,
two boys.
understandable.
They're 15 and 17 years old. I see them every
Mm-hmm.
6 weeks, 5 weeks, whatever we can. Uh,
Mm-hmm.
but it's for a good cause. So
Mm-hmm.
the practice in Austin is going to be called Voxel Endodontics. So
Awesome.
it's a cool
Awesome.
name. I had two options here. The other option was going to call Gentle Art Endodontics. You know what Gentle Art is. So
Yeah. Sure.
so those
Yeah.
are
Yes.
the two
Yes.
options for
Yes.
the practice. I register both names just in case, but Voxel is
Sure.
the winner
Smart.
right now. And what I'm also doing, I'm putting together a teaching institute. So the teaching
Mm-hmm.
institute is going to be for imaging, of course,
Mm-hmm.
because that
Mm-hmm.
work continues. So I have partnered up with a couple
Yes.
of companies,
Good.
which I unfortunately cannot quite disclose yet, but there's going to be a
Mm-hmm.
teaching center there that's going to be dedicated to train specialists in general dentists on the 6 pillars of imaging, like I explained. Uh,
That's
and
awesome.
then also, this is going to be open to all the dental assistants in the area. So I'm going to be happy to train them on how to properly take panels, properly take PAs, how properly take cone beams, regardless of the system that they use. Um,
Mm-hmm.
there is going to be also a training center for clinical endodontics, which will involve lasers and advanced irrigation. Um,
Mm-hmm.
so this is actually a done deal. And This will probably be
That's
up and
awesome.
running sometime in the end of October, November. And yeah, so from there, I'm dedicating myself to clinical endodontics. This is why I went to school and did all this. And on the
Hmm.
side, a little bit on the side, I'll continue to give my lectures and my courses, just because it
Hmm.
is it is kind of like what I love doing as well. And
That's
hopefully, if anybody is in the Austin area, want to stop by, say hi, and grab a barbecue afterwards,
mhm.
you're more than welcome to. Absolutely.
Yeah. Austin's such a cool area. Yeah. In fact, I I go there. Seems like at least once a year, last couple of years. So we'll
Right.
definitely have to
Yeah,
get together
come
for a
stop
good
by.
Brazilian churrascaria or
Yeah,
something
no,
like that
we'll
there in
come to
Austin.
roll. I'm part of the Brazilian Factory gym there. It's one of the top three gyms in Austin. My son
Awesome.
is really into jiu-jitsu right now, like crazy,
Nice.
crazy, crazy,
Yeah.
and yeah, so it's been fun.
That's
I'm,
good.
I'm an old man. I move slow. I'm just like the old anaconda kind of thing. Just go very slow.
Ye-
I'm not into this crazy competition kind of a mindset. I grew up in a different style of jiu-jitsu. A lot of the jiu-jitsu I learned, it was really old school. A lot that
Mhm.
was dedicated for street fighting and MMA per se. Uh,
Mhm.
Interesting enough, I don't know if you know this, but if you watch the old Pride fights, like the old Pride championships in
Yeah.
Japan,
Yeah.
all the fighters from Rio, like from the
Mhm.
Castle Gracie team back in the day,
Mhm.
if you
Mhm.
watch them fight, so if you watch, Murilo Bustamante, Nogueira, uh,
Mhm.
uh, Ricardo Arona, or Zemario
Mhm.
Sperry, all those guys, Carlon Barreto, all those guys, Vitor Belfort. Um,
Mhm.
if you watch their mouthpieces, it's always going to be white, green, or yellow. I made every one of those.
Yeah. Good
My
point.
nickname was Doc back in the day. I was training under Ricardo Liborio, who was the head of American Top Team, and under Murilo Bustamante,
Oh
and
wow.
one day, and I
That's
was I
crazy.
was sparring partners with Vitor Belfort for a fight,
Wow.
uh, and he was fighting Gary Goodrich, and then
Mhm.
Vitor was like, Bruno, I need a mouthpiece. You're a dentist. Go figure this out. And I was like, oh, cool. So I went to talk to one of my professors at the time, the pros department. He taught me how to make those guys with EVAs,
Yeah.
and sure enough, I would go to the gym, take molds of everybody and um, create their mouthpieces. So if you watch all those crazy fights, all those mouthpieces I made them, which is kind of a weird. Um,
Oh, that's so
yeah,
cool,
so that
man.
was
That so you were one of the OGs. I mean, from the other end, but still making the mouthpieces, being a training partner with Vitor Belfort and all these. I think the Nogueira brothers, at least who was it? There's some of these guys that are in Texas now that have moved to
no, the Nogueira Barons are
which
in
or
Rio. They live in Rio. They have the Nogueira,
okay,
yeah.
okay,
So
no,
so
no, no,
Minotauro and Minotauro
maybe
are
it's the
the
Machado brothers. I
yeah.
think
So
are
Minotauro
in.
and Minotauro are there in Rio.
Got
And
it.
just to give you an idea, like back in the day, those guys were they were poor. They didn't have any cars. I used to drive them to the
Hmm.
gym because I had a car. We were neighbors.
Yeah.
So, I think about it, I was like, holy shoot, those guys, didn't have rides to the gym, and now they're like multimillionaires, super athletes around the world.
Hmm.
Um,
Hmm.
I was just a big body and knew enough jujitsu that they were just thrown into the fire. So my job was just to get beat up every day and suture people when they, open up a nose or an eyebrow or whatever. Did that a lot
Yeah.
too. And it was fun.
Hey, I.
I grew up doing that, and it's
Mhm.
almost like an honor to be there getting your butt kicked by those guys. Only,
Oh,
only,
iron sharpens
only,
iron,
only
man.
those, yeah,
Iron.
only those
That's
who,
so
who've
cool.
done and understand it. But
Yeah.
interesting enough, when I moved to the U.S. in '05, um,
Hmm.
I was the first black belt in San Antonio, Texas.
Wow,
Um, and
that's cool.
I arrived in San Antonio. I was even a brown belt at the time. I got my black belt in the U.S.
Hmm.
Um, I arrived at the time as a brown belt, and
Hmm.
I said, well, there's no place to train here. So I emailed a bunch of people and I said, hey, I'm from Brazil. I'm going to be living here for a year. I'm looking for a place to teach. Is there anybody here that's interested in hiring me? And I got three
Hmm.
emails. The first email was
Hmm.
from a school. It was a Taekwondo school, And when I walked in
Mm-hmm.
there were like three guys with Brazilian Jiu-Jitsu gis and black belts. And I'm a brown
Yeah.
belt. All right. So I was like, okay,
Yeah.
so, and there's like this Regan Machado sign or whatever. I was like, okay, so why you guys want me here? And goes like, oh, we want you to teach because we're not really Brazilian black belts. We are Brazilian Jiu-Jitsu black belts. We are Taekwondo black belts, but we were the Brazilian gi when we teach the Brazilian
Yeah.
Jiu-Jitsu class. I was like, well, let's roll a little bit.
Yeah.
And I just
Yeah.
destroyed those guys. Like you have no idea. They were like
Oh,
white
sure.
belts, but with
Yeah.
that
Yeah.
pose. So they offered me a
Yes.
job on the spot.
Yeah.
And so I was teaching there twice a week, and then I got a phone call from a guy that had a
Mm-hmm.
garage group, um,
Mm-hmm.
which was Team Tadmock, which is combat spells backwards, James Walker, and he introduced me to this Japanese jiu-jitsu school that used to that had this beautiful mat, and they closed every day at 7 p.m. So I was like, "Do you guys? I will rent the mats from 7 to 10, and I'm going to
Mm-hmm.
teach class."
Mm-hmm.
So I went in,
Mm-hmm.
and all this garage group came for a for a class. They got hooked, and then the word spread. And within like a couple
That's
months, I had
cool.
like 60 students, and I was teaching from seven
That's
to ten
awesome.
every day. Um,
Yeah.
and then what I did was, well, I was hooked with Sergio Maha from Brazil, who was my one of my instructors. I was affiliated
Mm-hmm.
with him, and I said, Maha, I need you to come to teach a seminar for us. Uh,
Mm-hmm.
the school is growing; they want more. There's some money for you to be made here. Uh,
Mm-hmm.
so we went to a friend of mine who had a church, and we did a
Mm-hmm.
demonstration. And we said we're trying to collect money to bring my teacher here. Somebody there said, "Oh, that's what you need. Okay, I'll pay for the ticket." And within 2 weeks, Maha
Mm-hmm.
was in the U.S. He's still here, never left. My gym became his gym, and later on, I had to go in
That's
and open
awesome.
my own gym again. And I spent that 4 years in San Antonio going to graduate school, and I paid my way
Mm-hmm.
out of my all my schooling, teaching jiu-jitsu, teaching
Right.
MMA.
That's so
Yeah.
awesome.
So
That's so
at
awesome.
that time,
You know what? And on that note, and by the way, we definitely have to do this again, maybe in
yeah,
whatever, 6 months or a year, once you're up and running in Austin, and go do this again, because you're gonna be. I just know you. What people are gonna look back at this and see what you're doing 5, 10 years from now, and it's gonna be unbelievable.
I hope so.
And just as a wrap up, because one thing with lifestyle dentists, we do want to, our goal is to do well business wise, financial wise, but also lifestyle, have a
Yeah.
lifestyle that we enjoy, that we don't want to necessarily retire from just because we enjoy what we're doing. When you think of like an ideal lifestyle, what are some thoughts that come to mind for you?
you know, that maximum that goes body mind first is it
Mm-hmm.
always comes to mind. So
Mm-hmm.
I can tell you from somebody that's been on a roller coaster on this. Um,
Mm-hmm.
from I truly understand folks that are stressed, that are
Mm-hmm.
not being able to have the lifestyle that they want for different
Mm-hmm.
circumstances. Like even right now,
Mm-hmm.
um, I'm a resident, so
Mm-hmm.
with three other jobs on top of that, and a family that is
Mm-hmm.
1,500 miles away from me, and it's really really
Mm-hmm.
hard to
Mm-hmm.
have the time or having the discipline or even the energy to take care of yourself because you always have to put
Mm-hmm.
something in front. I have to wake up in the morning, got to read cases, got to go to the hospital, got to do cases, come back, study
Mm-hmm.
those other things, and then in the meantime, you don't have time to eat right, you don't have time to rest or to sleep or to even
Mm-hmm.
do something uh, fun socially for yourself, right?
Mm-hmm.
Um,
Mm-hmm.
so what I've learned in the past few years is that
Mm-hmm.
uh, there are a couple things that if you do, you can start resetting yourself
Mm-hmm.
to be more productive and be more efficient.
Mm-hmm.
A guy
Mm-hmm.
that maybe one day you can have him on your podcast that has a fantastic lifestyle
Mm-hmm.
is another endodontist out of Washington, D.C. named Scott Hetz. I don't know if you know Scott Hetz.
What's his
Scott
name?
Hetz. Yeah,
Scott
yeah.
Hess. I
So
need.
Hetz,
How do you know how to spell his
yeah,
last name?
Hetz.
I'm gonna look
Yeah.
him up.
So
Yeah, no,
Scott
that'd be awesome.
Hetz
Thank you.
really good friend of mine. He was the first one, together with Bill Nadira from Chicago, that have this very kind of a regiment sort of a lifestyle. They go to work, they go to school, they go
Mm-hmm.
to bed early, and they wake up very early. And so they're up
Mm-hmm.
at 4 in the morning, and by the time 7 a.m. rolls up, they have done more things than most people will have done by the time noon rolls up. But they were the ones that introduced
Mm-hmm.
me to Wim Hof. So I started to do the breathing
Mm-hmm.
techniques. I started to do the ice cold baths and the hot saunas,
Cold
and I
plunge.
know
Yeah.
you're in that too.
Yeah.
Um, so they were
Yeah.
the ones that introduced this to me. And what I can tell you is that what really changed within my lifestyle was the sleep. For my whole
Mm-hmm.
life as a radiologist, remember, I worked in the dark the whole time and never had any
Yes.
windows or anything like this. I always thought of myself as being a creature of the night, as I would do my best work
Mm-hmm.
at 3 in the morning, and I would try to
Mm-hmm.
sleep in. And what residency did to me was to show that with a little bit of discipline, you can sleep better and feel
Mm-hmm.
very refreshed, so you can do more.
Mm-hmm.
And
Mm-hmm.
suddenly I started to realize that I can go to bed at 8:30, 9 p.m. And I see a lot of people that says, "Oh, but I like to watch a show. I like to watch a night show or this." And I used to do this too. I used to watch like some of those
Mm-hmm.
night talk shows, and typically at midnight,
Mm-hmm.
12:30, after I watched that, that's when I would go to bed, and then wake up at 6, and I only slept
Mm-hmm.
5 hours. So now I go to bed at 9.
Mm-hmm.
I wake up at 4. I had my 7, 8 hours of
Mm-hmm.
sleep. I'm very rested. And you know what I do? I just
Mm-hmm.
open, when I'm taking a shower in the morning, I play the YouTube videos of the clips of whatever shows I like to watch. So I'm all caught up, and I'm just taking a
Yeah.
shower, right? And then I go to
That's
work, and
awesome.
I'm,
Yeah.
I'm very focused on that. So focus on your body,
Mm-hmm.
focus on your mind, focus on sleep.
Mm-hmm.
Exercise is
Mm-hmm.
crucial. Ideally speaking, the moment I go back
Mm-hmm.
to Austin, my routine will be
Mm-hmm.
exercise in the morning first, wake up early, exercise
Mm-hmm.
in the morning first, get charged up,
Mm-hmm.
then go do what I need to
Mm-hmm.
do, and keep focusing on
Mm-hmm.
my sleep. Of course, if you're out one
Mm-hmm.
weekend with a family member, it's okay, but the sleep is key.
Mm-hmm.
That's probably
Yeah.
from what I've learned in residency, and that's the most thing that has
Mm-hmm.
changed was my sleep schedule.
Mm-hmm. Mm-hmm. That's great advice. Man, this has been amazing. Really, they're definitely one that people are going to want to listen to more than once because you dropped a ton of knowledge, a ton of gold on this
Thanks, man.
podcast,
Thanks for the
Bruno. So I
invitation.
can't thank
Appreciate
you
you.
enough. We really need to do this again
Anytime.
when you're up and running in Austin, and look forward to it, my friend. And thank you so much. And please know, any way I can help with your start up the practice, with anything else, you reach out. You got my cell phone, so
Absolutely, man.
love to
I
help any
will.
way I
Trust
can,
me, I
brother.
will.
Please do. All
All right.
right. Hey, thank you so much. And
Yes,
with that, everyone, have a great day. Best wishes.
absolutely. Happy happy journey for
Take care.
everybody, and keep pushing the button, my friends. That's always my trademark. Goodbye. It's like, yeah, keep pushing that
I
button.
love it. Keep
Keep
pushing the
scanning.
button.
Keep scanning, my friends. All good.
Take care.
Cheers.
Thanks, guys.